Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at California Health Sciences University. Today we will be discussing nutrition screening and assessment. The reason why it's important to discuss nutrition screening and assessment is that whenever a patient comes into your care, whether it be in an acute care setting such as a hospital or an ambulatory care type setting, such as that you would see with skilled nursing facilities or nursing homes, it's important to determine a patient's nutrition risk. And the reason why it's important to determine nutrition risk is that can actually be associated with the outcome of your patient's stay. Patients who tend to have poor nutritional status or even malnutrition have higher rates of morbidity as well as higher rates of mortality. Therefore, it's very important to be aware of their nutritional status whenever they come in, as well as to monitor it throughout their stay in your healthcare facility. Our objectives today will be to compare and contrast different malnutrition syndromes, to list potential clinical and laboratory indicators of nutritional status, and describe the nutrition screening process. We're going to start out with the patient case. GB is a 25-year-old female presenting to our primary care physician for a routine checkup. Vitals taken at the beginning of her appointment include blood pressure 120/65, heart rate 85, respiratory rate 16, and oxygen saturation 98, with a height of 5'7" and a weight of 105 pounds. Prior to her appointment, labs were obtained, including a serum albumin of 2.1, and you see the normal range there, and a pre-albumin of 10, also seeing the normal range here. GB's past medical history is significant for generalized anxiety disorder and depression, currently on Venlafaxine XR 75 milligrams by mouth daily. She reports lack of appetite and a weight loss of 25 pounds since breaking up with her boyfriend 3 months ago. Question 1. What type of malnutrition syndrome does GB most likely have? Acute disease associated, chronic disease associated, starvation associated, or none of the above? Question 2. Which may indicate that GB is malnourished? Dietary intake, serum prealbumin, weight loss history, or all of the above? And question 3. If GB becomes hospitalized, when should nutrition screening be performed? Within 24 hours, within 48 hours, within 96 hours, or within 1 week? After we discuss nutrition screening and assessment today, you should be able to answer each of these questions confidently. To give you just a little bit of background of malnutrition and why malnutrition is so important to recognize, malnutrition is associated with increased complications. And this can be complications related to your patient or even complications related to your healthcare facility. So some that are related to your patient include poor wound healing, such as protein calorie malnutrition. If your patient is not getting adequate amount of protein, they may be predisposed to poor wound healing if they have a wound. Immunocompromised status. If you don't feed a patient, they may become immunocompromised as a result of lack of stimulation of different inflammatory markers and immunoglobulins in the GI tract, such as IgA, which promote immunity. If you don't stimulate that IgA, essentially you can become very immunocompromised. Organ function impairment. So if a patient does not eat, they may have a decrease in the amount of organ function that they have, such as with the lungs, as the lungs are very dependent on energy to function. It can even go to your liver, to your kidneys. Any organ that you can think of requires energy to function. So if you don't have essentially energy, then your body cannot function the way it should. One related to healthcare entities includes cost. So if you have a patient that has malnutrition or is malnourished, in those cases, there's actually a higher cost and a higher utilization of resources associated with these patients. And some of it may not necessarily be due to the malnutrition itself. Some of it may be due to the disease state that is the primary reason why they're in the hospital. But malnutrition is a risk factor that can actually potentiate further illness and further need for a hospital stay, and even further need for post-hospital care, such as that which you would get in a skilled nursing facility or a nursing home. In addition, malnutrition is associated with mortality. In general, depending on the type of practice setting that you look at and the criteria that you use to determine malnutrition is prevalent in about 30 to 50% of whatever population that you look at. And that can be decreased or increased again depending on what practice setting you look at. One thing to distinguish very carefully whenever we talk about assessment and screening is actually, what do screening and assessment actually mean? So nutrition screening is a process to identify an individual who is malnourished through the use of appropriate screening and assessment methods. So essentially, it is a simple way to identify patients who are malnourished through a few different parameters, whether that be, a handful of parameters or multiple parameters. However, a nutritional assessment is different in that it is more comprehensive than a nutritional screening per se. And it's a more comprehensive evaluation to make a diagnosis of a malnutrition syndrome and guide intervention and expected outcomes. So there may be more components associated with nutrition assessment versus nutrition screening. However, a lot of times in practice, you'll actually hear these two terms interchange. So if you hear the term nutrition screening and nutrition assessment, you may potentially interpret them to be similar things, depending on the tool that is used to do the screening or assessment. And we'll talk a little bit about some of the tools that are used a little later. Before we start to actually assess and screen our patients, we have to be aware of what we're actually looking for in terms of malnutrition and malnourished status. So there are many different malnutrition syndromes that are out there and many different classifications of malnutrition syndromes that are out there. Some that are related to a particular disease state, some that are related to inflammation, and some that are related to particular environmental factors. Now, your book, the Aspen Core Curriculum, divides these malnutrition syndromes up into those that have a degree of inflammation, which are acute disease associated and chronic disease associated, and those that do not have a degree of inflammation, such as starvation associated. So, in general, many malnutrition syndromes have some kind of degree of inflammation as a key contributor, and that can be related from an actual disease state. So essentially, a disease state here is the driver of that degree of inflammation that's going on. So that's actually broken down into two parts: acute disease associated and chronic disease associated. So acute, thinking just about that word, is more associated with something that is within the now, something that is potentially new. And these things include things like major infection, which is also known as sepsis, burns, particularly severe burns, second and third degree burns particularly, trauma. Closed head injury is another acute disease associated type of malnutrition syndrome. In terms of patients who have chronic disease-associated malnutrition syndromes, they may present with chronic organ failure, and really organ failure can fall into acute or chronic. Some chronic organ failures that you may see include end-stage renal disease or even cirrhosis. Pancreatic cancers and cancer in general can be a chronic disease-associated type of malnutrition syndrome, assuming that malnutrition develops. Rheumatoid arthritis, which is already an inflammatory disease state. And then something else called sarcopenic obesity. What sarcopenic means is essentially low muscle mass. And obesity obviously means that the patient has a BMI above 30. So what sarcopenic obesity is that these patients actually will have a high BMI but low muscle mass. So in a way, even though they're obese, they don't have a lot of muscle mass to actually stimulate a lot of the normal bodily processes that we would need muscle for. Now, in contrast to those malnutrition syndromes that have inflammation as a key contributor, there are many malnutrition syndromes that don't have a degree of inflammation as a key contributor. And typically we call those the starvation-associated malnutrition syndromes. And those are things such as anorexia, or even some kind of other compromised intake in the setting of a psychiatric illness, such as depression or anxiety. So essentially, these patients don't have a chronic disease state that's necessarily driving the malnutrition itself. The patient essentially is just not getting enough food volitionally. Now, yes, depression may have an influence over anorexia, and in that case, you could potentially argue it to be a chronic disease-associated malnutrition syndrome. But in this case, I would associate it more with a starvation-associated, as the patient would most likely not be eating. Which this actually brings up an interesting point in that patients may have more than one malnutrition syndrome present at one time. And they may have the potential to change between different malnutrition syndromes depending on the situation at hand. So say if, for example, an acute disease-associated malnutrition syndrome develops eventually into a chronic disease state, in that case, there might be a change from one to the other. So what do we look at whenever we're determining whether or not a patient has a degree of malnutrition, or if we're trying to nutritionally screen or assess a patient? Nutritional assessment of patients can include a variety of different indicators that we look for to determine whether a patient is malnourished or has a degree of inflammation. In regards to this, we look at things such as the patient's history and their clinical diagnosis, their clinical signs, as well as physical examination, anthropometric data, laboratory indicators, dietary data, and also functional outcomes. And we're going to go into each of these different parameters to explain what each of them is. Now, in terms of each of these different parameters, the list can go on and on regarding what things that you can actually see or assess in terms of your patient, given, the limitation that we have 1 week to discuss this. Your textbook actually has a lot of great examples of some of the different things or different aspects of each of these components, and I'll highlight a few of them as we talk about each component. So the first thing we're going to talk about is history and clinical diagnosis. So whenever I talk about history, I'm talking about the patient's history and any kind of diagnosis that they have that may potentially influence their dietary intake or even a degree of inflammation. So elements included within the patient history and the clinical diagnosis include the patient's body weight, and this includes things such as their usual weight, what their peak weight is, whether the peak weight is a peak low weight or a peak high weight, as well as deliberate weight loss attempts or even undeliberate weight loss attempts. Sometimes patients will deliberately want to lose weight as part of a diet and exercise regimen, but there are some cases where patients undeliberately lose weight, such as those patients that may have some kind of malignancy such as cancer, or even patients who, have other symptoms associated with weight loss, such as nausea, vomiting, diarrhea. Medical and surgical conditions, both acute and chronic, can affect your nutritional status. So say if you get a pretty massive GI surgery completed, that may actually affect what you're able to eat after that, depending on if they remove certain parts of your bowel. Medical history is also very important. Kind of like we were talking about in the example earlier, anxiety and depression, as well as other psychiatric illnesses, can play a big role in terms of the development of other starvation-associated malnutrition disorders. In addition, we also have to be very wary about different types of things that our patients are eating and how that can influence some disease states like diabetes, hypercholesterolemia, or even hypertension, as all those things can contribute. If a patient has eating difficulties or gastrointestinal complaints, they may have problems swallowing. A lot of patients that are post-stroke, for example, may not be able to eat or do activities of daily living on their own after that. Or if the patient has significant nausea, vomiting, constipation, or diarrhea, that may preclude a patient from getting their most adequate nutrition intake possible. Again, eating disorders pops up here under history. Medication use. So many different drug-nutrient interactions exist which can either affect the absorption of nutrients or the absorption of other drugs. In addition, medication use is also very important as it may affect your nutritional status. Say if you're on, a lot of laxatives, for example, or if you're taking lots of laxatives, that may promote things such as diarrhea, and obviously a higher evacuation of the bowel, which may minimize the actual absorption that you get in the GI tract. Other medications that can affect your nutritional status include things like loop diuretics or Lasix, particularly, as this can flush out a lot of fluids and electrolytes that your body has. Certain dietary practices and supplement use are very important to talk about with your patients if possible, because that may actually influence their current dietary status and nutritional status. And then any kind of other influence on nutritional status, such as their functional status. Are they able to walk around? Are they able to feed themselves? Do they need a caregiver to give them food or to feed them? And then what is their lifestyle like? Are they able to move around? Are they able to, eat certain things? Are they very picky in terms of the foods that they want to eat? Do they exclude certain foods or eat more of other foods that may be bad for them, like junk foods and fast food? It all should be evaluated. Next portion we'll talk about are clinical signs and physical examination. So these are things such as your vital signs, even as indicators of inflammation. You may see patients have fever, hypothermia, and tachycardia. All these are different signs of inflammation that exist, but there are tons more signs of inflammation that are present. In your physical exam, You may see patients have edema from a loss of total body protein or albumin. You may see weight loss or weight gain in terms of their weight loss or weight gain history. You might want to check a BMI. Are they actually underweight? And in terms of your physical exam, whenever you do your physical exam, if you see certain abnormalities, that may be indicative of certain nutrient deficiencies that a patient may have. Now, these aren't necessarily what I would call foolproof diagnostics. For example, if you did, a hand grip and leg extensor strength test on a patient to assess what the level of their strength is, it may not necessarily be the one indicator that they have bad nutritional status. Or, for example, say if you see that they have thinning hair or a change of hair color that may be different from when you saw them last. It may not necessarily be an indicator of nutritional deficiency. Maybe they're just getting old and their hair is thinning. That's why it's important with the physical exam and with all of the different findings that we discussed today, that it's important to realize that not one finding will limit you to getting malnourished or a malnutrition diagnosis. It's many different things that you have to actually have to be considered malnourished or a malnutrition status. So, like I said, hand grip and leg extensor strength are important to use to determine the ability of your patient. You may look at their hair. Is it thinning? Is it changing color? Is it easy to, pull out? Do you have any hairs that are left on your pillow at night? Is it easily falling out? Skin. Do you have, any new wounds? Do you have any skin discoloration? Eyes, perioral, extremity, physical exam is important. Another one that may be important is your mental status, and nervous system exam. Is your patient, have a normal mental status? Do they have any other past medical history, or some kind of unknown medical history, or some kind of new diagnosis of some kind of psychiatric disorder that may play a role in their actual nutrition status? In addition, functional status is very, very important to always assess on every patient. So, do they have normal gait and balance or coordination? It may not necessarily be an indicator of poor nutritional status, but if you see a change in gait and balance and coordination from the last time you saw them, do you think that patient will be able to adequately function on their own to be able to get the proper nutrients into their body? Or do you think they might need assistance in trying to do that? These patients actually may have a higher risk of becoming malnourished if they're not able to do their own activities of daily living on their own. Another type of data that we look at is anthropometric data. So this is essentially all of the different measurements that we can do for a patient. So these are things like your height and your weight, which together, height and your weight can produce a BMI. And BMI, typically less than 18.5, is significant for patients who are underweight and at risk of malnutrition. Skin folds and circumferences may also be used. However, a lot of the literature says that these are not necessarily reliable, depending on your certain situation. Though things like waist circumference are, highly utilized whenever you're assessing for things like metabolic syndrome. You can also use some other body composition assessment tools, such as DEXA scan, which we commonly see used to diagnose osteopenia and osteoporosis. Essentially, with the DEXA scan, we can use it to kind of determine your bone mineral density. CT and MRI scans can also be used to determine areas of visceral fat. However, these are not commonly used for this purpose, as they require lots of training to be actually performed. And in terms of determining nutritional status of a patient, in terms of the cost of the patient, the cost overall that these different scans will cost is much higher than the utility of actually determining your risk of nutrition or your nutritional risk status. Essentially, you have a lot of other data that is available to make these determinations, though CT and MRI are still different types of tools you can use to assess a patient. As pharmacists, it's always important for us to be aware of different laboratory parameters that are out there that may be indicative of poor nutritional status. So some things that we may look at in terms of determining nutritional status include serum albumin, serum prealbumin, and C-reactive protein particularly. With serum albumin and serum prealbumin, the difference between albumin and prealbumin is that albumin actually has a longer half-life where prealbumin is much shorter. And prealbumin, as a result of its shorter half-life, may be a little bit more reliable than albumin in general. However, if you have any kind of degree of inflammation, these proteins will actually be altered in their production, and as a result, they're not reliable. That's why in many cases, whenever you obtain these different labs, you might want to get a C-reactive protein level or a CRP level, which essentially is a positive acute phase reactant that if the CRP level is elevated, it may indicate inflammation. So say if you have a patient who has a high CRP level, their serum albumin and prealbumin level most likely won't be too reliable. But if their CRP level is normal or low, in that case, you may use serum albumin and prealbumin with a higher degree of confidence, even though it's important to note that no single laboratory test or panel can make a diagnosis of malnutrition, just as with all of your other physical assessment and nutritional assessment tools that you have at your disposal. Other things that we may look at include white blood cell count. If you have an elevated white blood cell count above 12,000, it might indicate a degree of inflammation. Same thing with serum glucose. If you have a serum glucose above 180 to above 200, it may indicate some kind of degree of inflammation or some, systemic inflammatory response. Another thing that we may look at, depending on its availability at the institution that you may be going to eventually for rotation or in your career, is nitrogen balance. And what nitrogen balance does is it indicates a degree of catabolism and protein replacement adequacy. So essentially, with nitrogen balance is equal to your amount of protein over 6.25, and that's grams of protein, minus your urine, urea, nitrogen plus 4. Something that's important to note here is that this actually has to be done with a 24-hour urine collection, which makes it a little bit more difficult to do. And ideally, depending on your different nutritional situation, if you have a nitrogen balance of 0, that means that you're getting an equal amount of catabolism and metabolism, essentially, so making and breaking down of protein. However, if your nitrogen balance is low, that might indicate that you have a significant amount of stress or a loss of protein, and a positive nitrogen balance may indicate a level of higher protein replacement. Again, whenever you're looking at all these different laboratory indicators, it's important to realize that no single laboratory test or panel can make a diagnosis of malnutrition. And the same can be said with all of the different tools that we talk about today. There is no one single thing that you can assess that will tell you whether or not your patient is malnourished. You may have a high risk of malnourishment as a result of determining if one of your factors is out of range, but ideally you should look at the whole patient picture. One big piece of information or pieces of information that you should obtain is dietary data on your patient if you have it available. So some methods to do this include a food diary if your patient is outpatient, 24-hour recall, food frequency questionnaire, diet history, and obviously one of the big things you can do is direct observation if you have them in a closed facility. This table from the core curriculum of Aspen actually tells you a little bit about each method and the procedure and limitations of each of these different tools. Probably the most common ones that I would think you would see in practice include food diary, especially if you're on the outpatient side, as well as direct observation. And direct observation is done more along the inpatient side or in the event that your patient's in some kind of closed facility like a skilled nursing facility or nursing home. In terms of food diary, patients essentially can write down what they're eating in exact quantities. However, the limitation of this is that the recording of this might influence their actual food intake, and patients can get very overwhelmed in actually taking the food diary. In contrast, direct observation is another tool you can use, and it's essentially just visual examination of a meal before and after it's served to the patient. And it's used a lot of times in hospitalized patients or residential patients, and may include what we call a calorie count to assess if a patient's meeting their nutritional needs. So essentially what you can do is you can actually take a look at each thing that the patient is eating and put a calorie amount to it that corresponds with that type of food and add it up to see if the patient actually meets their requirements. Some limitations of this obviously are if the meal tray is removed or discarded before the clinician can observe this. Otherwise, some other healthcare providers may do the observing, such as nurses. Food intake cannot always be estimated just from the amount that is on the tray. Just keep that in mind because, for example, someone else, like a member of the patient's family, may eat part of the tray. And in that case, your amount that you're measuring from that meal tray is not going to be necessarily reliable. In addition, there may be high variability of your clinician's ability to estimate portion size. So one thing that is commonly done in the inpatient side is that they may assign different percentages depending on how much a patient has eaten in a day or even at one meal. So for example, if they go in, they eat breakfast and they see that they eat probably about half of their breakfast, they can make an estimation, the healthcare provider can, that the patient ate 50% of their meal for that breakfast. However, that 50% may be very subjective because somebody else may say 60% and some may say 40%. And while you think that 40% and 50% are not that far off, whenever you're actually doing a full calorie count of an entire day, it can make a very big difference. Another big thing that we look at in terms of determining nutritional status is functional outcomes. So we're looking ideally at their strength and physical performance, or what we essentially can determine their strength and physical performance to be. These are assessed through things such as hand grip strength, which is most commonly used, which is partly a little bit subjective in that it really depends on the person who's measuring that degree of hand grip strength. You may have, for example, someone who gives, a weak handshake, or someone who gives a very strong handshake. But remember, that's always determined by the person who's giving the handshake, obviously. So this can be a little bit subjective in itself. Other things such as gait and balance, if they're able to stand on a chair or step up onto stairs, are big things that may actually not only just show the ability of their body and what it can do, but also in terms of your muscle status and your ability to do activities of daily living. Are those patients actually going to be able to do things such as eat and move around on their own, or do they need assistance? So in general, nutrition assessment and screening are important in determining nutrition care. And the goal of nutrition assessment is to identify nutrition risk or malnutrition. And essentially, the nutritional assessment components are essentially what we listed previously as history, clinical signs of physical exam, anthropometric data, laboratory indicators, dietary data, and functional outcomes. So essentially, we want to look at all of these things whenever we make a determination about someone's nutritional status. We don't want to look at just one. We want to look at the whole history to get a good idea. Because, for example, someone may have a low BMI, but it doesn't necessarily mean that the patient is malnourished. We need to look at their other data, like their dietary data, their functional data, their clinical data, and their history to determine whether or not this patient is truly malnourished or not. So in terms of potential malnutrition diagnosis or a malnourished diagnosis, remember that malnutrition is a consequence of nutrient imbalance, and that can be macronutrient or micronutrient. And remember, we always have many factors to consider. It's not just one factor. But weight loss and energy intake are significant factors. So if you see here, depending on if you've had a history of weight loss over a certain period of time, or if you've had decreased energy intake over a certain period of time, that can actually predispose you to develop severe malnutrition. In addition, a BMI may also be a consideration, but again, a BMI is only as good as the other information that you have with it to determine if your patient's malnourished or not. So there's not necessarily one factor that can determine a malnutrition status. It's many, many different factors. Now we're going to just transition a little bit and talk about the nutrition screening process in a variety of healthcare settings. So nutrition screening is required in most healthcare settings, including acute care or hospitals, and in long-term care, skilled nursing facilities, and nursing homes. And the screening typically involves the use of some kind of instrument or set of standardized criteria to determine if an additional assessment needs to be done. So remember, screening is a little bit more simplified and may only include certain amount of parameters depending on your screening tool that you're using. If you're actually doing a full assessment, it might take a longer period of time to do. So everybody gets screened, but not everybody gets fully assessed, if that makes any sense. The Joint Commission mandates that every individual is evaluated for nutritional risk within 24 hours of admission to wherever they are admitted to, whether it be the hospital or a long-term care facility, so that those patients can get treated adequately nutritionally. And depending on the type of screening tool used, they will determine some kind of risk level, and that will determine your rate of rescreening. So those risk levels can be things such as determining if there's a risk or no risk at all, depending on the type of tool you use, or a low, moderate, high risk. So essentially it's a 2-parameter or a 3-parameter risk in most places. They may also score these as 1, 2, 3, 3 being the highest risk and 1 being the lowest risk. There's a variety of different things that they can do in terms of screening. A lot of times, in terms of nutrition screening, if your facility has dietitians available, a lot of times they are the ones that are doing the nutrition screening. And in terms of the different computer systems that are out there, such as Epic, Epic can flag certain parameters within a patient's chart to be nutritional risk flags for the patient, to where the dietitian may look at those patients more quickly than other patients who don't have those certain parameters. In other facilities where you may not have a dietitian readily available, nurses can also do nutrition screenings, depending on their level of training. Pharmacists can also do nutrition screenings as well, again, depending on their level of training, as well as physicians. So it really just depends on your scope of practice and what your training has been within that certain area to determine whether or not you think your patient is getting adequate nutrition or not. Depends also on your institution's protocols on who actually is responsible for doing that. In many places, it will be a dietitian or a nurse, but in some places, the pharmacist may actually be doing it themselves. This diagram kind of gives you an idea of what happens in terms of that nutrition screening process and nutrition care process. So whenever a patient is first admitted, they undergo some kind of screening within that first 24 hours. And if they're not at risk, they're going to undergo periodic rescreening. However, if they are at risk, they're going to undergo a further assessment, which, remember, that assessment is a bit deeper than the initial screening. Then a nutrition plan is developed, they implement the nutrition plan, and then they monitor the patient. If the patient needs continued inpatient care, then they continue to monitor. If they have a patient's change in status, so say if they got, more acute and had to be shipped, for example, from the floor of the hospital to the ICU, they may have to be reassessed. And vice versa, if the patient just came out of the ICU and went to the floor, or if they're about to go home and get discharged. Those would be what we would call change in statuses, and that would be reason to reassess the patient. So are your goals being achieved after this monitoring and implementation of your nutrition plan? Great, if they are. In that case, you may be able to continue the current therapy or even terminate the current therapy, depending on what level of therapy nutrition-wise they're on, whether it's enteral nutrition, parenteral nutrition, or even just oral regular feeding. Which, if it was just regular oral feeding, you may not necessarily need a termination of therapy. There are many different screening and assessment tools that are out there and available to use. I just list a few of them here. Some of the ones that you may hear more about out in practice are the subjective global assessment, which is an assessment tool that was developed in the late 1980s. But you also might hear about other ones such as the Birmingham, the Nutrix score, many nutritional assessments, and your core curriculum book actually lists dozens more. So there are many different screening tools and assessment tools that are available. I don't want you to get burnt out on trying to memorize each and every single one, because it's almost impossible to memorize which one is a screening tool and which one is not. I just want you to be aware that there are multiple ones that are out there for use. And this is actually what the subjective global assessment looks like. This was developed back in 1987. And you see here it goes through different components such as your patient's history, any dietary intake changes the patient's had, the presence of GI symptoms, functional capacity, disease and its relation to nutritional requirements, if your patient has a high metabolic or stress demand, So say if they're in the ICU, for example, they might have a high level of stress. But if they're not sick at all, they're on the outpatient side, they may not have any level of stress. You might also do a physical exam that may indicate some kind of level of edema, muscle wasting, loss of subcutaneous fat. And then you will do a rating. And depending on your assessment above, you can choose well-nourished, moderately nourished, or severely malnourished. And again, it's a subjective global assessment, so not everyone is going to do this assessment the exact same way. It's important to realize that this is subjective, not objective. And not all the different assessments are like this. There are some that are more objective than not. But with nutrition, as you saw, that we're looking at many different parameters, including your physical exam, your history, your lab parameters, your weight loss history, your dietary data. A lot of this data has to be conglomerated together to make one decision at the end. So our overall conclusion from today's talk is that there are many different malnutrition syndromes that exist, and they may or may not involve inflammation. So those that involve inflammation are your acute and your chronic disease states, associated malnutrition syndromes, and then the ones that don't involve inflammation include your starvation-associated malnutrition syndromes. Nutrition screening and assessment may involve obtainment of patient history, physical exam, anthropometric data, laboratory indicators, dietary intake, and functional outcomes, with all elements being important. Not one area is greater than the other. You want to look at the patient's entire picture when determining a patient's nutritional risk. And another important point is that all patients in acute and long-term care settings should receive nutrition screening within 24 hours of admission, and periodically thereafter, depending on their nutritional risk. Here are the references for today's talk. And back to our case, we had GB, a 25-year-old female, presenting to her primary care physician for a routine checkup. Vitals include blood pressure 120/65, heart rate 85, respiratory rate 16, oxygen saturation 98%, a height of 5'7", and a weight of 105 pounds. Prior to her appointment, her labs included serum albumin of 2.1 and prealbumin of 10. Normal 15 to 36 for the prealbumin, and normal 3.5 to 5.5 for serum albumin. Her past medical history significant for GAD and depression, currently on venlafaxine. She reports lack of appetite and a weight loss of 25 pounds since breaking up with her boyfriend 3 months ago. So what type of malnutrition syndrome does GB most likely have? The answer here is GB most likely has starvation-associated malnutrition syndrome. And the reason why is because of her recent weight loss of 25 pounds within the last 3 months. And if you remember back to the criteria that we had for potential malnutrition, weight loss of 7.5% or more over 3 months may indicate malnourishment. Her GAD and depression may play a role in her weight loss. However, these disease states are not necessarily inflammatory disease states that would be considered an acute or chronic disease state associated malnutrition syndrome. In order for there to be an acute or chronic disease state, they have to have some kind of degree of inflammation to be considered one of these two types of malnutrition syndromes. Next question, which may indicate that GB is malnourished? The answer here of the 4 answers is all of the above. So, as we stated, GB's appetite has been relatively low. She's lost a lot of weight recently. 25 pounds within the last 3 months. And if we looked at her serum albumin level here, her serum pre-albumin level, was 10, which is low. And this is essentially an idea of her nutritional status. Now, ideally, we would want to obtain a CRP level to determine if there is actually any inflammatory process that's going on. But there's no inflammatory process that we're not necessarily aware of in this case, as she only is here at the PCP's visit for a routine checkup and has GAD and depression, which are not inflammatory mediated diseases. So has a low prealbumin and a low albumin level. That can indicate nutritional risk. In addition, she has a BMI of around 16 if you look at her height and her weight. If you added back the weight of 25 pounds, her BMI would probably be within the normal BMI status. And she reports a lack of appetite. So as a result, all of these are different factors that may indicate GB is malnourished, not just one factor alone. We have to look at the whole assessment of the patient. And the last question, if GB becomes hospitalized, when should nutrition screening be performed? And the answer here is within 24 hours, as the Joint Commission requires it to be within 24 hours. If you wait longer and your patient is malnourished or has a high nutritional risk, you risk the patient developing more complications down the road associated with that baseline malnutrition. And that can lead to further morbidity and possible mortality, as well as higher healthcare cost and utilization. If you have any questions regarding nutrition screening and assessment, please let me know. Thank you and have a great day.